My co-host is Shruta Rawat from the Humsafar Trust, a reputed community agency working with sexual and gender minorities. The webinar's focus is on HIV pre-exposure prophylaxis, or PrEP, in India. The webinar aims to provide a brief update on clinical and research aspects of PrEP, and we will also deliberate on the way forward for introducing and scaling up PrEP programs in India. We look forward to some very enriching discussions with our eminent speakers and panelists. They will present information on the topic from diverse perspectives. It is with great pleasure and honor that I invite Dr. Mayer, Dr. Gilada, Dr. Sahay, Dr. Kumarasamy, and Mr. Abhishek as speakers and panelists today. Thank you very much for graciously agreeing to share your valuable insights in this webinar. Welcome. I now invite Shruta to take us through the agenda and logistics. Yeah. Shruta, you are on mute. Yeah.
We all start our webinars like that. Thank you for the warm welcome, Dr. Chakrapani. I'll just provide a brief insight into what our agenda and the logistics look like. We will first begin our panel discussion with a presentation by Dr. Kenneth on best practices and next steps of PrEP, followed by Dr. Gilada's talk on contributions of PrEP to larger HIV prevention, and Dr. Sahai's presentation on PrEP research scenario in India. We will then continue with a panel discussion with our panelists. The webinar is open to access right until the end, so I would encourage all of our attendees to share the link with any friends or colleagues who would like to join in. So speakers and panelists will take questions after presentations by all of our speakers. But in the meanwhile, if any of the audiences listening in have a question, we would request them to use the Q&A feature to just indicate questions. And it would be great if you could indicate the speaker whom you would like to direct your questions to, along with your name and your organization's name, if you'd like to share that as well. So the webinar is being shared live on Humsafar Trust Facebook handle, and it will be uploaded to YouTube later for a later view. The recording will also be available on C# and Humsafar Trust website. And with this, I would now like to hand over to Dr. Chakrapani to invite our first speaker and formally initiate our webinar.
Yeah, I would like to now invite our first speaker, Dr. Kenneth Mayer. So Dr. Kenneth Mayer's research career in HIV and public health has spanned several decades with over 1,100 peer-reviewed publications. His seminal work during the 1980s included developing the very first COVID studies, series of groundbreaking HIV prevention trials, and prevention interventions to respond to the HIV epidemic. Most notably, his role as an investigator on the HPN-052 and IPREX trials. Well known for his work with marginalized communities, Dr. Mayer is the Medical Research Director of the Fenway Institute at Fenway Health, the largest lesbian, gay, bisexual, and transgender community clinic in the USA. He is also a professor of medicine at Harvard Medical School. Welcome, Dr. Mayer. So I would request you to start your presentation.
Thank you. I'm going to share my screen, and let's hope you can you see the slides now?
Oh, yes, we can.
Wonderful. And hello, everyone. Good evening and good morning from the United States. I want to thank Humsafar for this kind invitation. It's great to see colleagues like Dr. Gilada, Dr. Sahay, and particularly my dear colleague, Dr. Kumarasamy, my first collaborator in India now several decades ago. So I'm going to try to overview what we know about PrEP and coming up the new year 2021. And the joys are trying to get the slides to move. Okay, so what is PrEP? It stands for pre-exposure prophylaxis. So this is the use of antiviral medication to prevent HIV infection. This is an approved regimen around the world. The main regimen is tenofovir, disoproxil fumarate, and emtricitabine, two drugs used to treat HIV. They're co-formulated. They're taken as one pill once a day, and they're quite effective. WHO also approves on-demand PrEP for MSM. So that's 2 pills within 24 hours of exposure and a pill a day for 2 days after. That's so-called 2-1-1. In many countries, including the US, this is not a standard regimen, but there is an evidence base from studies in France that support that. And there are other regimens. There is a drug regimen using tenofovir, alafenamide, TAF, and FTC that is approved in many countries as well, but very often is more expensive. So in terms of what do we know about PrEP? In this slide, you can see all the different studies, the initial placebo-controlled trials, and you can see a linear plot. And basically, some of the studies showed excellent effects with PrEP, and in those studies, people were highly adherent. There were several studies in women where women were not adherent for a number of reasons, and there was not great efficacy. So the take-home is we know that PrEP works for all populations, but it only works if you take it, and there may be less forgiveness for some populations than others because of pharmacology. So whereas on-demand PrEP has been studied in men who have sex with men and achieves high concentrations in the rectum, so there's the ability to take potentially less drug. For cisgender women and probably for transgender women, it's important to take the drug on a daily basis. What do we know about the real world efficacy? Because what I showed you before were the clinical trials. Clinical trials, you may say things might be better in a clinical trial. There's a lot of staff that support the clinical trial that are coaching participants. But in the real world, this analysis done by Jared Baton from several dozen studies basically showed that overall the HIV incidence in people who took PrEP in the real world was under 1% per year. And the group that seemed to have the highest incidence were transgender women. And again, not that PrEP doesn't work in transgender women, but there were more issues of adherence, concerns about drug interactions with hormones, which were not actually not a problem in terms of the PrEP medication affecting hormones. And that's why education is going to be so important for all populations. If we think about adverse events, they really are quite minimal. There can be creatinine elevation, so renal effects of tenofovir disoproxil fumarate, but these can be readily managed. And in terms of severe adverse events with creatinine, those are not statistically significant. Fractures were not more common. We know that tenofovir can affect bone, but not at a level that it has clinical repercussions. So overall, a very impressive safety profile. So these are the guidelines in the United States for who is PrEP eligible, and I believe they are similar in India. You want to make sure that somebody has a negative HIV test, preferably a 4th generation antigen antibody test, so we don't start treating people when they're in the window. We want to make sure they don't have acute HIV infection. We want to obviously look for counterindicated medications, and we'd like to know people's hepatitis B status because tenofovir and emtricitabine can treat hepatitis B, and if somebody has chronic hepatitis B, we'd like to know that because there's a risk of hepatic enzymes flaring if we stop PrEP. So we would have to know if we're starting somebody with chronic hepatitis B on PrEP that they're essentially agreeing to go on the medication for a lifetime if they want to avoid liver injury in the future. As mentioned, TDF-FTC is the most common regimen, and this is indicated for all populations at risk for HIV, but there is a creatinine clearance threshold. On the other hand, TAF has a lower creatinine clearance threshold, so we can give it to people with some increased evidence of renal insufficiency, but it's only been studied in men who have sex with men and a limited number of transgender women. So certainly individuals who are assigned female at birth, in other words, people with a vagina, cisgender women, transgender men, we would not recommend TAF-FTC. So I mentioned efficacy may be a bit less in women in terms of the trials. This is a summary of the different studies, large efficacy trials in women. And what you can see in the middle in the graph is basically if women had at least 75% adherence, they decrease their risk of HIV substantially. So again, PrEP works if you take it. The question for transgender women is not that the tenofovir is going to affect the estrogens, it does not, but the estrogens increase renal excretion of tenofovir, so that you may have a lower level relatively. So this means that transgender women need to be highly adherent to PrEP. In other words, taking it on a daily basis. But they take it on a daily basis. The studies show that they will achieve the same benefit as other populations. In terms of people who inject drugs, there's only been one efficacy trial. It showed modest benefit, but again, there were questions about adherence. This was a study conducted in Bangkok. And with people who inject drugs, it's very hard to separate whether the protection is exclusively because of protection from the exposure through needles, because many of these individuals may be having sexual contact with people with HIV. So the data still are sufficient to say that people who inject drugs will be protected if they use PrEP, and scaling up PrEP for this population is also extremely important. There are challenges for PrEP adherence in adolescent men who have sex with men. In the United States, the indication for PrEP is based on weight now and not on age. So individuals as low as age 13, in theory, can get access to PrEP. We were involved in 2 studies in the Adolescent Trials Network, the ATN. These studies involved counseling and PrEP. The one, ATN 110, was an 18 to 22-year-old young MSM, and ATN 113 was in young MSM aged 15 to 17. And you can see HIV incidence is really higher than we would be very comfortable with. And what we found was the problem was adherence. Adherence fell over time. The first 3 months of the study, adherence was not bad, and we asked the youth to come in on a monthly basis for counseling. But after that, we extended the visit cycle to quarterly, and then the incidence went up and adherence went down. So we think that one of the take-homes here is that if you're prescribing PrEP for youth, you really need to make sure you have a very good program to ensure optimal adherence. One concern that many clinicians have had about PrEP is that there may be more sexually transmitted infections. And these are data from Australia, which basically say, yes, you may see more STIs during PrEP than before PrEP. But it's very important to unpack this. In other words, people who go on PrEP are often going on PrEP because they do not want to use condoms. So rather than saying, I won't give you PrEP because I'm worried that you'll get sexually transmitted infections, I think the more appropriate approach, because you don't want the patient to not get PrEP and to become HIV infected, is to say, I will initiate PrEP, but you need to understand that if you're not using condoms, you're at risk for gonorrhea, syphilis, and chlamydia. And therefore, you need to come in for routine screening for STIs. So our protocol, we tend to screen people at least quarterly for STIs when they're on PrEP because of the increased risk. And we continue to counsel about condoms, not in a judgmental way, but we just, again, explain from a harm reduction standpoint. The PrEP will protect you against HIV, but it won't protect you against anything else. So you really do want to use condoms if you're worried about syphilis, gonorrhea, or chlamydia. And if you're not using condoms, you need to come in for regular STI screening. There are a number of barriers. PrEP uptake in the United States is not what we'd like, and certainly we know that in India it has not been scaled up adequately in relation to the populations who could benefit. Certainly, part of this is on us as providers. In other words, we can do a better job of educating our patients and being educated ourselves. So I congratulate everybody here on the webinar who is a provider, just because this means that you're interested in the topic. There certainly are issues of medical mistrust in the US. There's a lot of racism, and so we have to really explain to people who are at risk for HIV that this is not some nefarious plot of the medical establishment. And building trust with key populations, I think, is an extremely important part of PrEP care, and certainly ensuring access. So in the US, we have various programs to increase access for people who are at risk for HIV, because these may be individuals who are very poor, who may live in remote areas. So we use telemedicine sometimes as part of PrEP. And we also know that PrEP is only part of the issue. So medical care means also ensuring that people have shelter, have food, have other needs met. And we have to think of that as clinicians as well, and think about how people will pay for it. But again, the one thing we can do is educate ourselves and educate our patients. Another issue is the importance of culturally competent care. So particularly because this is a program sponsored by Humsafar, which is a preeminent organization in India focusing on sexual gender minority health, it's important to really call out the fact that many providers are not comfortable taking care of sexual gender minority people, but these are individuals who can benefit a great deal from PrEP. And so we don't want to be the problem. And there are tools now. I put at the bottom a web link. This is our National Education Center at Fenway Health. It's sponsored by programs for the US government, LGBTQIA and just to give you an example, learning to deal with our implicit biases towards sexual gender minority patients, we have tools, you can download them from the web. And the important issue is to think of the fact that culturally competent care is a basic human right and essential for optimal clinical outcomes. One other point I'd like to make for those of you who are general medical providers, it's important to think about PrEP also as a gateway to care. We recently had a paper published from our experience at Fenway in the American Journal of Public Health. Because as I mentioned, if you're going to be screening people for sexually transmitted infections on a regular basis and checking their creatinines and refilling prescriptions, this means that you're having a group of people who normally think of themselves as healthy coming in for primary care. So we looked at our clinic and we said, if we look at people who are on PrEP compared to what we knew of who were MSM who weren't on PrEP, what was the difference in healthcare utilization? And we found that PrEP users were more likely to get an influenza vaccine the previous year. They're more likely to have their clinician ask them about their tobacco use to screen them for depression, and even screening for diabetes, hemoglobin A1C, or glucose testing. So we would argue that PrEP is part of a package. You're taking care of the whole patient, and this is an opportunity to interact with patients. The other thing I'd like to mention, and we don't want to ignore the fact that PrEP today is not what PrEP is going to be in the next few years. So this is just a list of all the different approaches using antiviral medication for prevention. And it's not even just antiviral medication, because there are studies looking at monoclonal antibodies as well that may be things that we can offer people. So the tenofovir-based PrEP is PrEP 1.0, but you can see at the bottom, there's a vaginal ring that has been shown to be effective that is now approved by the European Medicine Association, not yet, to my knowledge, approved in India or the United States for that matter, but that's a question of time. And this offers some modest efficacy for women who may not want to be taking a pill every day. And then injectable PrEP, there have been 2 studies in the HIV Prevention Trials Network, HB10-083 and 084, that have shown that injections of cabotegravir, an integrase strand transfer inhibitor, every 8 weeks are superior to actually oral medication. So in the future, PrEP may be an injection, but right now we should focus on PrEP 1.0, tenofovir-based PrEP. And lastly, I just want to mention, formatting here didn't come out so great, but this is a collaboration. This is a project funded by USAID with NACO, and this is being conducted by YRG Care, led by them and Johns Hopkins, and we're collaborating with them, and this is developing tools. It's called Accelerate. I put on the web link here for information that is available for patients. And the Fenway Institute's role has been to develop some course materials that can train providers in PrEP provision, and that those modules are coming online shortly. So with that, I'm going to stop because we have some other excellent presentations and look forward to the discussion. Thank you.
Thank you very much, Dr. Ken. I think after we hear from the other 2 speakers, we will open up the panel discussion. So I will request Shruta to introduce Dr. Gilada.
Thank you, Venki. So Dr. Gilada is an HIV, STDs, and infectious diseases consultant at Unison in Mumbai and honorary secretary of People's Health Organization India. He is also the president of AIDS Society of India and a governing council member of the International AIDS Society. He has published and presented over 290 papers at conferences and in journals and books, and he has won 75 awards for his work in management of HIV, AIDS, STDs, and infectious diseases. Dr. Gilada, the floor is all yours.
Thank you, Shruta. This has been a great honor for me to be at this platform for 2 reasons. One is Humsafar Trust, founded by a great friend of mine, Ashok Rao Kavi. before 1990, when a handful of 5 or 6 people were there involved in HIV work at that time. And secondly, because I'm sharing the floor with father of PrEP, I call Ken Mayer, father of PrEP. He taught the meaning of PrEP and long form of PrEP to the entire world. And my colleagues are there, um, Kumar Swami and Dr. Sahay. So I think this is one of the most important forum for me to be here and to be of any assistance to the community. May I share my screen? I don't know. Am I able to share my screen?
Yes, doctor, you should be.
Okay, good.
Yeah.
Good. Because I'm not so much proficient in my IT sector.
Right.
Anyway, what I would like to focus is, though the question has been, uh, can PrEP contribute to larger HIV prevention? And if you look at 1990, we are lacking something which is prevention. And in that, PrEP in the private sector. So I think currently PrEP is only in the private sector. So I'm going to focus on that. Now, when we look at the gap, this 90-90-90 focus, which is 90% people should know their HIV status, 90% of those who know their HIV status, they should be on ART, and 90% of those who are on ART, they should be virally suppressed. Where is the prevention here? So there's no prevention goal in this. And you can look at what are the paradigm available where we can have prevention, and one of them is PrEP. So if you look at what are 10 different preventions available, currently hardly we have 3 or 4 with us. Treatment as prevention is there, HIV testing, counseling is there, male condom is there. Female condom is mostly in the books or we just hear, it's not practically available. Treatment of STI is very, very disorganized in this country. And male circumcision as a treatment procedure for preventing any STD or HIV, that is not used at all. So when we look at what is a microbicide, hardly anything available. So we are only PrEP and PEP that is available. And that too, PrEP is not yet approved in Government of India for the public usage. So who are the people who can be candidate for PrEP? If they are discordant couple, one person is positive, one person is HIV negative, they are the fit people. Otherwise, those who engage in sexual activity within a high prevalence area or social networks like Grindr, Tinder, etc. And one or more of the following, basically diagnosis of any STD or partner of unknown HIV status, or those who are using injection drug use, or people in incarceration, or inconsistent use in condom use. Because when we talk to partners also, they say that, no, that is my fixed partner, but that fixed partner may have another fixed partner. And then exchange of sex for commodities or in job circumstances for some favors. So all those people in these circumstances can be fit partners, fit people for taking PrEP. Now, what is the strength of private sector? Private sector, by and large, non-judgmental and non-discriminatory approach. The rapport and good communication, and that helps in ensuring adherence. It's a long-term commitment. Those who are in private sector in HIV practice, they are there for many years, maybe 10 years, 20 years, 30 years, 30 plus years. The knowledge about PrEP on HIV-related issues, they are specialized, and they are abreast with current developments. Whatever new things are coming up, they are abreast. Adverse effects of managing any adverse effects, and all drugs or different combos are available in private sector. Now, Ken has shown this slide. I want to only emphasize one particular point on this. Is effectiveness of PrEP is important, and that is only with adherence. So if you are 100% adherence, you get around 86% results. So as adherence goes down, the results are going up to 0 if your adherence is only 30% or less than that. Now, there has been discussion at NACO. We have been also interacting between ASI and NACO at national conferences, and PrEP has been topic for almost 4 or 5 years. Most of the times, Ken has addressed the group, and they have come to some level where there has been discussion happening at NACO. There's a technical resource group on HIV treatment. There's a concurrence and approval of NACO. TRG was sought on the draft guidelines. The guidelines are still draft for PrEP, which have been developed in consultation with the community, program managers, and private practitioners. Since these guidelines would serve both public and private sector, there are 3 WHO approved regimens are proposed. And those are tenofovir emtricitabine, tenofovir lamivudine, or TAF with emtricitabine. However, DCG has approved only the first one, that is tenofovir and emtricitabine for PrEP. The draft current guidelines recommended daily PrEP, but there is no role for demand PrEP or on-demand PrEP for MSM population or LGBTQ population. So TRG has approved these technical guidelines, but it has to be finally approved in the guideline committee, and they are yet to be implemented. So this happened about 3 months back. Now, understanding PrEP, you should understand, because a lot of people would ask a basic question: how expensive it is? Because the term looks very fancy, but it is not expensive. It's 1,000 to 2,000 per month, depending on what combination you are using, and depending on what kind of discount you are able to arrive or derive from any chemist or any place we are buying. It cannot replace condoms. So a lot of people would think that I'm using PrEP, but there are other 19 STDs. STD diagnosis and treatment is crucial. So a lot of times we ignore a lot of STDs. People who are purely in HIV work, they do not look at STDs as a package. People talk about those vaccines which are not available. Everybody is now focusing on COVID vaccine, but there are vaccines to prevent two very important STIs. HPV, Tata Hospital study shows that 1/3 of the oral cancers are because of HPV. Hepatitis B vaccination. It is part of universal vaccination program since 2011, but it is only for children. What about adults? And their HPV is expensive because it is an imported vaccine, but HPV is a very cheap vaccine. Commercially, it is available for 100 rupees per dose or something. You need 3 doses for entire lifetime. Physicians should be astute in diagnosing and management of acute HIV infections. As I said, there only 86% protection is there. So some people, despite being on PrEP, could be getting acute HIV infection. So the physician should understand that acute HIV infection. Now we done a study between AIDS Society of India and Gilead to look at the impact of COVID-19 on at-risk population, PLHIV, and the provider community, that is doctors. I'm just presenting 3 or 4 slides from the at-risk population sector, and there are 10 countries study, including India, and their total respondents were 1,077. Now, if you look at India, we had given a quota of 30 people from all the 3 categories, but you can find that at-risk category of PLHIV, we could, despite all the efforts, we could get only 14 or 10 people to respond, because people are scared. Nowadays, with the data productivity, etc., they are scared that their information will go somewhere and they will be trouble. So they don't want to even log in. They don't want to come in online. So prescriber could be more than 30, but despite all our efforts, we could not get more at-risk people to respond. Now, impact of COVID, there are other impacts also, access in care and ART, etc. But 2 most important for the at-risk population is HIV prevention care. It was almost unavailable during the entire lockdown period. Now, unlock period 4, 5, 6 onwards, they are able to get, but neither they could go for any preventive checkup nor for any treatment. And similarly, adoption of online consultation. Though other PLHIV community and non-HIV related people, they could adopt to online consultation, but LGBTQ or people at risk, they are still not comfortable in coming online. So if you look at close to half of the risk population reported a concern in their long-term availability of HIV preventive medicine during this lockdown. And the same thing has been shown in India. They were concerned and 20% were neutral. And access to HIV testing, it was very, very low at that time. At least 50% was lower than expected. So take home message and way forward is at-risk community, especially MSM and LGBTQ population, continues to be marginalized. So despite legally we have untangled a lot of issues, but still they are marginalized. PrEP is yet to be approved in public healthcare, thus it remains a private healthcare domain. PrEP is inexpensive, but mindset is very expensive. It's very difficult to change the mindset of people in the country. PrEP drugs in all combinations are easily available. For the best results in protection, adherence is most crucial, and private sector should walk a mile extra and network with the communities where it is required the most. So let us PrEP well. That is my topic. That is my take-home message for all of you. Thank you very much.
Thank you for the very insightful presentation, Dr. Gilada. I would now like to invite our next speaker, Dr. Seema Sahai. Dr. Seema Sahai is engaged in social behavioral research for the last 21 years. The focus of her research has been on community engagement and social behavioral research in HIV vaccine trials and microbicides. Her current areas of interest are domestic violence, key populations of HIV research, which includes communities such as female sex workers, men who have sex with men, people who inject drugs, and adolescent populations. She is the PI for a demonstration project on PrEP among men who have sex with men and transgender women. Dr. Sahay has published over 80 papers and training modules on sex education, community engagement, and intimate partner violence prevention, as well as several book chapters and books. So, Dr. Seema Sahai, I would like to invite you for your presentation.
Thank you, Shruta, and good evening to all my colleagues and everyone. So I'm going to talk about PrEP research scenario in India. So Dr. Ken Meyer has already talked about why we need PrEP. So we also know there are existing guidelines on PrEP, and in India, Dr. Gilada has just talked about approval of TDF and FTC in 2016. We are doing demonstration projects right now, and PrEP, which is available, it is available online, and sometimes it is being prescribed by private doctors, or otherwise it is available in the demonstration project. So the research so far in India is like willingness to use PrEP has been assessed. Dr. Chakrapani had done, and his group has done discrete choice experiment among men, men having sex with men, and 88% acceptability was seen for PrEP. And in the demonstration project among female sex workers, 85% willingness to continue taking PrEP was reported by Reza et al. In 2019. However, when we look at the gaps, recently ICMR NARI conducted a study among hidden MSM, hard to reach MSN, and we found access to healthcare was a challenge, lack of knowledge, there was invisibility of program in the rural setting. There was, people did not have belief and in the quality of service that were available, and stigma was experienced at government health facilities. So as you can, I have also shown some of the quotes. I go to government facility and it will be unnecessarily advertised. So people are really, really afraid of stigma. And they also do not know if there are programs available, particularly in rural settings. So we see a lot of geographical disparity. We also see there is less of acceptance for available programs right now, and therefore there are gaps for delivery models. What should be the delivery models for PrEP rollout if it is to be rolled out in the country? And there are various structural issues that are available. If I looked at the published work, it fitted into one page from India. So we have very limited research work that has been done, and we need research in our country. In India, we have conducted two demonstration projects. One is completed among female sex workers, which is by Dr. Jana and his group, and the other one, which Dr. Gilada just now mentioned, among men having sex with men and among transgender women, which is an ongoing project and which we are conducting at ICMR NARI, and I'll be talking about it. So in FSW demonstration project, we saw this study was conducted at two places, Mysore and Kolkata. In Mysore, high self-reported adherence was seen. However, this is unpublished report from Kolkata. The adherence level was quite low in the FSWs who participated at Kolkata side, and those reasons are to be investigated. The ongoing study, which is being conducted in MSM, is being conducted to understand the real world, what are the issues that would come with real world setting, which would include identifying populations that would benefit the most from this additional HIV prevention option. Oral PrEP may also close a critical gap prevention gap for men having sex with men and transgender women in India. And up till now, there has been no demonstration project of feasibility study of oral PrEP by MSM and TGW in India. So this is the first study that is being conducted, and it aims at implementation of daily oral TDF, and the outcomes that we are looking for. It is retention rate, acceptability, adherence, side effects, and toxicities, and incident STIs. And there are others secondary objectives to this particular study. And the study is being conducted at Jalandhar and in Pune, and the sample size is 800, 400 at each site. During the lockdown, since it is an ongoing study, initially there was good recruitment and good adherence. As you can see in the beginning, 77% of people had 100 to 95% adherence, but this adherence reduced with the situation of COVID. So as Dr. Gilada just now talked about COVID, so we have suffered from this particular problem, and how to bring care to the community, it's going to be a challenge for everyone. During the COVID lockdown, we have seen a reduction in face-to-face visits to CBO. We also met the challenge by, we also saw that people got relocated, and people who work from home, it brought a big shift. So people have not been able to get PrEP in the demonstration project when there was lockdown. So recruitment was stopped in the mid, and now it has been initiated right now. What is working is some of the innovative approach, and digital platforms are really working, and it's really helping us in recruiting participants for this particular study. Looking at the future or the areas of the study, areas or issues where studies need to be conducted, we saw in the literature review, we saw that there were adherence challenges. There was wide difference between self-report and actual drug levels. So studies needs to be done, and the reasons were both clinical and socio-behavioral. So initial symptoms like nausea, vomiting, these were the reasons stated, but there was low risk perception among the participants. There was a stigma for PrEP because it was associated with HIV infection. Misconception was there for HIV infection or sex work. People also had some issues about product characteristics, and there was fear for long-term effect. Decision making is again limited. Theory-based socio-behavioral research is required because this is a challenged population. Mostly, many of them are abandoned, isolated, abused, transition sex is there, Guru Parampara is there, where individual level decision making is very difficult. Online access versus prescription, this is another issue which needs to be studied, because unmonitored PrEP usage could result in risks to users. So adverse effects due to excessive dosing, HIV infection due to insufficient dosing could be there, and development of resistance. This could be there, and that is why this area needs to be investigated. Healthcare level barriers are also seen for the PrEP. There is a paradox. Those healthcare providers who are specialists in HIV, in managing HIV infected patients, they and the general physicians, they have so much of phobia about PrEP. They have transphobia, they have stigma about PrEP. So this kind of paradox, purview paradox, is seen among healthcare providers, and this again need to be explored and studied well, and for the program needs to work on this. There are implementation research needs. We need to plug information gap, because in our study, we found that MSMs or TGWs, they were not even aware of the existing centers. There were structural barriers, delivery modes, which delivery mode will be suitable, community-based or facility-based, and then uptake of PrEP decision-making, retention, and adherence. In adherence, sustained adherence is extremely important. This needs to be studied. Then disparities in getting providers in different geographical area. In rural area, there was no such facility available, or people were not aware. So this disparity also needs to be researched. Then PrEP awareness campaigns were found to be limited. One of our participants said, lack of information penetration, what government is doing for awareness is not sufficient. So strategies to increase access to PrEP is required. To summarize with, there are gaps in implementing PrEP, and which we need to see. We need to look at delivery models. Social behavioral research needs to be done to study acceptability, adherence, and sustainability, and community awareness strategies needs to be developed. So community voices need to be included. Demand generation has to be done. So finally, cost effectiveness would be extremely important from the view of PrEP research and acceptance of PrEP by the communities. COVID interruptions. So we need to be prepared for these kinds of interruptions now, because we have faced that interruption. So what kind of delivery model should be used? What kind of digital platform should be used? This is going to be a new way forward, which needs to be researched strongly. And PrEP initiations have been there in the country. National guidelines for PrEP among high-risk population in India is being developed right now, and evidence is needed. So demonstration project is being done right now in the country. Thank you.
Thank you, Dr. Sahay, for highlighting the importance that behavioral research plays with PrEP. I would now like to hand over to Dr. Chakrapani to take this ahead.
Yeah. Thank you. I think I will first introduce the two remaining panelists before we move on to the actual panel discussion. I will start asking questions to Dr. Ken, because Dr. Ken may need to leave in another 15 minutes or so. So first I will introduce Dr. Kumarasamy. So Dr. Kumarasamy is Chief and Director of Infectious Diseases Medical Center at Voluntary Health Services Hospital in Chennai. He has 25 years of experience with over 400 articles in peer-reviewed medical journals. He has conducted several landmark antiretroviral clinical trials, which had impacted HIV treatment guidelines and implementation of HIV programs in developing countries. He is an advisor and expert panel member for the World Health Organization's Antiretroviral Treatment Guidelines Committee and a clinical advisor to Clinton Health Access Initiative. Currently, he is the regional representative for Asia for AIDS Clinical Trials Group of NIH. Dr. Kumarasamy ranks in the top 2% of scientists worldwide in the field of virology. Yeah. Thank you, Dr. Kumarasamy, for joining us. And I would request Shruta to introduce Abhishek.
Thank you, Dr. Chakrapani. So Abhishek Desai is a communications and media strategist at Hiv, a campaigning non-profit that works across social political issues that range from sexual and reproductive health and rights, gender sensitization to climate change, and youth capacity building, as well as engagement. With a background in journalism, his articles have been published on online platforms, including Hindustan Times and DNA. As an intersectional queer feminist, he's passionate about youth sexual and reproductive health and rights, and advocates for rights of marginalized communities. He was a part of Harvard Kennedy School leadership, organizing Action 2019 cohort designing, a campaign for holistic support for HIV prevention and PrEP in India. Thank you for joining us, Dr. Kumarasamy and Abhishek. Dr. Venkatesan, up to you.
Yeah, I think I will start with questions to Dr. Ken, considering the time we have with him. So I think, Dr. Ken, I think one of the questions which are commonly asked both by the practitioners and also by the policymakers is, if PrEP is part of combination HIV prevention that you need to use along with condoms, what is the additional advantage of using PrEP in, like say, practice or in national programs? Why can't we just strengthen the condom use? So that is one aspect from which some policymakers and clinical practitioners, they also ask. And again, during the consultation meetings, I have also heard that policymakers and program managers, they are concerned about what is called as risk compensation. As you know, like whether people will engage in increased risk behaviors, whether it is sexual or injecting drug use, under the assumption that now they are protected by PrEP. So what would you like to say to the practitioners and policymakers on these aspects?
Yeah, these are really important questions, Venkatesh. I think we have to reframe the way we think about these issues. It took a number of years, but I think that many people are aware of the whole concept of harm reduction for people who inject drugs. And I think the same thing has to apply to sexual health. In other words, sexual health is an intimate part of human experience, and it's an important part of health. The same way nutrition is part of health. These are, experiential, conditions of humans. So we need to say, what tools do we have as clinicians to offer people so that they have the least harm that occurs to them? We certainly can have personal preferences. We certainly, doesn't mean that we don't respect monogamy, but monogamy may not be an option for some individuals. Some individuals may be in forced sex situations. Other individuals may prefer non-monogamy. It's not for us to make that decision. So the important thing as a clinician is to say, what tools do I have at my disposal right now to work with my patients, my clients, to help them make the best decisions so that they will have the best health outcomes. So it's not either or. In other words, if somebody says to me, I want to minimize, absolutely minimize my likelihood of getting HIV and getting an STI, I'd say, well, PrEP works almost 100% of the time, though there have been rare cases of transmission of resistant virus. So condom will give you added protection against HIV, though only a small amount, but the condom will give you, a lot of protection against these other STIs. So that's why you may want to use a condom in PrEP. But if you're somebody who's not going to use a condom, I'd rather you use PrEP than say, gee, I'm not going to make PrEP available because I'm concerned that you won't use condoms. Because this gets to the other idea of risk compensation. This goes back to the idea that if you put seatbelts in cars, will people drive faster? And this is something that ethicists talk about as moral hazard, the idea that you might be encouraging bad behavior through a new, making a new option available. And the reality is that in most parts of the world, we're seeing unprecedentedly high rates of continued transmission of HIV, despite the fact that we know that U equals U, undetectable equals untransmittable. And that is because there's still a fair number of people who don't know their HIV status. There's some people with HIV who are not engaged in care and not taking medication regularly. So relying on getting everybody treated and therefore no HIV will be transmitted, that's aspirational. But in the meantime, we know that individuals who are HIV infected can protect themselves. So why wouldn't we want to make them available and give them access to something that can protect them against HIV?
Yeah, thank you, Ken. So I will ask Dr. Kumarasamy if you have any overall comments or questions for Dr. Ken.
Ken, probably you gave an excellent talk, as usual, and it was a pleasure being working with you in the more than last 2 decades on, HIV prevention here in India. So you, now, you talk a lot about this oral PrEP and the disease and the, data which is being published. But now we have, 2 studies on the long-acting injectables. Do you want to give any comments on this and this future usage in a country like India for prevention?
I'm happy to, Dr. Kumarasamy, but I also think it'll be important for you to add some context and maybe Dr. Gilada, because what I can tell people is the fact that we have these 2 studies, but at least in the United States, to get something approved by our Food and Drug Administration means putting in applications, and it takes time to review those data. So I can tell you as an investigator in the first of the 2 studies, the injectable study in men who have sex with men and transgender women, we're still only cleaning the data right now. In other words, you can finish a trial and say, gee, this effect was shown, but the FDA wants to say, well, what were all the side effects? And if there were side effects, how do they resolve after a certain period of time? So that study is not even fully, the dossier isn't even ready yet to go to the regulators. And then the women's study only finished a few weeks ago, but that'll be prepared as quickly as possible as well. So what I'm saying is that it'll probably be several months into 2021 before there's an application to the Food and Drug Administration, they'll take their time. But as you might imagine, they're spending a lot of their time, the infectious disease part of the Food and Drug Administration is pretty focused on COVID. So how quickly they can turn this around and give approval, not clear. But I would be optimistic because the data looks so good that by the end of the first quarter of 2021 or so, there should be an approval in the U.S. So the question I have back for you is that this is a new drug in the United States. I'm sure it's going to be quite expensive, and I don't know what agreements the regulators, the company has made with the regulatory authorities, the government in India, and I think you probably have a very good idea because you've been studying this drug for treatment and are very aware of these issues.
Sure, Ken. I think I will cover this during, my overviews when Venkatesh is asking the questions.
Okay. Yeah. Thank you. Can I request Abhishek if you have any comments or questions to Dr. Ken?
No, I think as someone who represents the community and as actually the end user, I think the entire talk, all the three presentations have been so insightful. I think as the end user and a community member, I've been a part of conversations, whether they were online or offline. I've interacted with people who do this work, but to actually hear from doctors and researchers, and especially Dr. Ken, Dr. Gilada, and Dr. Seema, the work that you're doing is astounding. I think for me, the biggest takeaway sort of was from Dr. Seema's presentation, where, not just the COVID challenges, but generally sort of when you look at PrEP and how stigma to get on PrEP is looked at. And then when you consider the socioeconomic barriers and why considering those intersections are so important when we would roll out policies for PrEP, right? So I think there have been a lot of takeaways from all the presentations, but yeah, thank you for having me a part of that.
Yeah, thank you, Abhishek. So Dr. Ken, I think as a follow-up of what Abhishek said, so what, you also mentioned about problems with adherence for women and adolescents. So what kind of adherence promotion interventions are being provided in, say, in your country, and which may be adapted for the Indian context? So that is one. And also Abhishek mentioned about the stigma. So regarding the PrEP-related stigma, uptake among, say, key populations, and also any PrEP-related stigma in terms of, like, say, prescribing it to the population. So whether what kind of experience are there from your country? So.
Thank you for those questions. In terms of adherence interventions, it's only recently that the US CDC has actually published some adherence interventions that have been part of research studies. So one of them is something that I worked with my colleague Steve Safran. It's called Life Steps for PrEP, and it's basically problem solving, and it's delivered by nurses, and it's 4 sessions where the nurses talk with the patients and sort of review and develop a program with the person about why they might have challenges for adherence. And if people are interested in this whole area, because that's just one of them, that's the one I'm most familiar with because I helped develop it. But the CDC, if you go to the website, cdc.gov, and then you keyword in PrEP evidence-based interventions, they've now taken a bunch of them and they say there's enough data here. But I think a lot of this is clinical common sense, and I think the biggest challenge is that many clinicians are very busy. So it's challenging to try to provide all the counseling that may be necessary. But I think there really are opportunities for task shifting, because a lot of the conversations about PrEP don't necessarily have to be done by a physician, that nurses may be much more accessible, may have more time, and peer counselors may be able to be trained as well and to provide support. So I think there's lots of ways to work with people. And it's really, again, the fact that the reasons for non-adherence, there's not like one reason for non-adherence. So it's trying to understand the person's life. Are they depressed? Are they having substance use issues? are they not out with their family and they don't have a place to hide the pills? Are they ambivalent about taking PrEP? Are they concerned about side effects or maybe misattributing something that's a health issue and they're blaming it on PrEP? So I think it's getting a good history is the first part of any good clinical interaction. And in terms of PrEP stigma, I think that's a very complicated issue because PrEP stigma, in countries like the US and India, where most of the people at risk for HIV are members of key populations now, a lot of the stigma gets back to the stigmas about the lifestyles of the individuals, the idea, that there's still a lot of homophobia in lots of places in the world, not just India, but certainly it exists there, transphobia, discomfort with people who inject drugs or sex workers. So I think that some of the stigma is more than just PrEP, but I think there's also this sense of, gee, you can solve this just by being monogamous. You can solve this by being abstinent. You can solve this by using condoms. Why do you have to use medication? And that's sort of a judgment that we as clinicians sometimes will make for people. And that's not very helpful because if that person really has reasons why they're going to engage in intimate behavior that might put them at risk for HIV, it's more important for us to say, how can I help you, not how can I judge you? But a lot of this is going to be, social media. I bet, Abhishek may have some better ideas than all of us working in media and working in the community about how we work in destigmatizing some of these issues.
Yep, thanks. Yeah. Shruta, are there any questions for Dr. Ken from the audience? Can you take over?
Oh, absolutely. Thank you, Venki. So we've got a question from Pallav Patankar, who's Director of Partnerships at Avgen. So Ken, the question is, what about usage of PrEP with other comorbidities such as hypertension, diabetes, hepatitis A, B, C, cholesterol medications such as statins? That's the first question. And the second one is on PrEP on demand. The question is, if a person plans a sexual encounter, can we offer on-demand PrEP or episodic PrEP, considering that the pill burden is lesser? With another attendee who has indicated as to why is event-driven PrEP omitted from policy recommendations in India. So I would actually urge the other panelists and speakers to think about this question in particular. But Ken, if you could have your insights on these two.
Yeah, well, hi, Pallav. It's nice to be in contact remotely. So your question about the medications and the comorbidities, it's really, again, this drug, tenofovir disoproxil fumarate, has been around for quite some time. Busy clinicians like Dr. Kumarasamy and Dr. Gilada know very well how to manage this very well. It's not a very complicated medication. So again, diabetes is a spectrum, so there's no counterindication if somebody has diabetes in taking this medication, but people with diabetes may have kidney issues. So therefore, a good internist, a good clinician will check their creatinine, and if the creatinine is anywhere in the range of 60, then they may have to recheck after they start PrEP sooner than later, and we'll check creatinines on a regular basis. In young, healthy populations, there's data that's from Kenya, for example, that says checking creatinine more than twice a year is not necessary. But certainly if I had a diabetic patient and their creatinine clearance was 68, I would certainly want to see them again at least quarterly to check their creatinine, maybe even sooner if they're having, proteinuria. So I think you individualize, but it's not the diabetes in general. It's how advanced the diabetes is in affecting kidneys. And similarly, there's no contraindication with statins or people who are on medications for cardiovascular diseases, but people who are on statins may have other comorbidities that might affect their kidneys, and therefore we'd monitor them more carefully. And there are occasional drug interactions, but not a whole lot. So we really mainly focus on renal function, and then rare situations, somebody has bad metabolic bone disease, that would be a consideration. And again, I don't know how easy it is to get tenofovir alafenamide, and I believe it's would be expensive in India, but probably certainly not as expensive as in the US. But that's another option if people have those comorbidities. In terms of the viral hepatitis, there's no contraindications for hepatitis A and hepatitis C. It's hepatitis B that I mentioned that we're concerned about because the medications that treat hepatitis B are similar to the medications that we use for PrEP. And in that case, it's not an absolute counterindication. It's just that you'd have to make sure that the person knew that it wouldn't be good for their liver to go on and off of the medication. So we'd have to make sure that they understood that if they were starting PrEP, they probably were committing to staying on it or some medication like that for the rest of their lives. And then the last issue about on-demand PrEP, I'll defer to my Indian colleagues about the government guidelines. What I can tell you is that various countries are very conservative about this because there's only been one large study. It was very well conducted in France, but there now are some studies to repeat it, but some regulators would rather see more data. The concern is not that on-demand PrEP doesn't work, because the French study showed that pretty well. The concern is that in the real world, if people are, not really being meticulous about how they take the pills, that might lead to bad consequences. So the important thing about on-demand PrEP is making sure that people take 2 pills within 24 hours of exposure and then a pill a day afterwards. And I'd be interested to hear from Dr. Kumarasamy, Dr. Gilada in the private sector if they've had requests for on-demand PrEP. But I think the government program is saying we'd rather just stick with the more conservative option because there's more data about daily PrEP. And the good thing about daily PrEP is you build up a drug level, so there's some forgiveness for MSM, for example, and also it's sort of a habit that people get into, and if they're tolerating the medication, it may be easier just you take your PrEP pill, you take your vitamin, than kind of planning, because for on-demand, you'd have to know sufficiently in advance that you're going to have sex to be able to have enough medication on in the system before having an exposure.
Yeah, thanks, Dr. Ken. Yeah, I think now I would like to ask Dr. Kumarasamy to briefly tell us about your experiences as clinicians on the use of PrEP. Especially, you have been using that among serodiscordant couples and men who have sex with men. So, how effective are they in your clinical practice? Please elaborate on that.
Right. Thank you for the question, and thank you, Ken, and other speakers for setting the pace for this panel discussion. After seeing all this data, India definitely needs biomedical HIV prevention in the form of PrEP, which has been lacking. Now, we initiated this initiative. I think Ken and Dr. Gilada and Dr. Seema Sahai will remember way back in the year 2017 in Chennai, soon after one of our ERT symposium called COT Symposium, bringing all the partners like NACO, ICMR, even AIDS and NIH and different other partners come together, start discussing and when to implement, how to implement PrEP in India. And today I'm glad to hear from Dr. Gilada that now finally TRG has been developed a draft guideline. Hopefully this will be implemented soon. So already 3 to 4 years delay. Science very clearly shows this works. So implementing PrEP will facilitate in ending AIDS epidemic in India, which we all know we have been working on how to end this AIDS epidemic. I think without PrEP, it might be very hard. I think it's time that we need to start working on. I think being a clinician, a lot of our work is on prescribing PrEP. In fact, in our clinic in Chennai at our hospital, VHS Voluntary Health Services, now we have been giving, the PrEP implemented in our clinic almost like 3 or 3.5 years back, and soon after it was being approved by the US FDA. And we have been using, and in our private practice, even before our Drug Control of India approved in India, we started using, and now we have approvals from Drug Control of India. So a lot of indications where, people come to us is, as you know, that our clinic in collaborations with Dr. Mayer and NIH and HPTN network conducted this famous HPTN 052 study, and we enrolled one of the largest number of serodiscordant couples, and we showed that treatment as prevention, and became a history, which we all know that. Now, since then, we have been following a very huge number of serodiscordant couples, for HIV care. So one of those pressing need among these couples is, to have a baby. So in the past, before we got this data from 052, we did different things. We tell them, you go and adopt a child, you do an artificial insemination, do sperm washing, so many things, we did this. After seeing this data on HPT and 052, we started counseling, right? Then when we said you is equal you, we started talking to them, hey, why not you, try this? And when PrEP was being approved in the US, that's the time we really got into this, campaigning both antiretroviral treatment in the infected partner and PrEP in the uninfected partner, where we prescribe PrEP and do the proper counseling. So just for this meeting, we looked into our, we have a large serodiscordant couple database, which again, Dr. Mayer helped us to set up, I think, 10 or 12 or 15 years back through one of our collaboration called Fogarty Collaborations. We still run that database and enrolling all the serodiscordant couple and characteristics and what treatment they have been taking, and with the partner who's been seroconverting. So we have a very strong PrEP program among the serodiscordant couple, where we have counselors do very detailed counseling on both the partners, both on the infected and uninfected partner, and offer HIV testing to the uninfected partner, hepatitis B testing, and of course do serum creatinine. And we make sure that the in-touch partner, that is the infected partner, have a undetectable viral load. If not there, we tell them, hey, this is not the right time. We like to have a child. Make sure that they take the drug, adhere to the drug, and we do a viral load when they have been undetectable. Then we talk to the uninfected partner. Now, this is your prescription. Talk about a very detailed about when to take it, how to take it, how long to be taken. Don't interrupt and all those. And we do this. I think in the last, several years, last, 3 or 4 years, we would have prescribed for more than serodiscordant couples on, PrEP to the uninfected partner. Both were male partner positive and women negative, and as well as the other way also. So mainly predominantly for, having a child. So just for this discussion, we also looked into the, a database. So among all those, the couples who received, we had seen only one person who had been seroconverted after taking that. So again, when we looked into that, the history being, okay, the index partner was a little irregular on treatment, and the woman who we prescribed PrEP who's been negative was earlier also been irregular. Then we looked into all those history, and probably this adherence would be one of those major factors. Again, you heard from Dr. Mayer from those studies, very clear that we don't have an adherence, we don't take it, you don't have an efficacy, which we again saw in that particular episode. So among those serodiscordant couple who received this PrEP for beginning having to have a child, so we analyzed 46 pregnancy in that. So out of those, 41 have already delivered, all have been negative, both is women negative and, of course, the child negative, and 5 are still on follow. Also, we had prescribed this PrEP to the other way, to the male partner who's been negative, and the woman being positive, where they had undetectable viral load, where we have seen these men, who have been, taking them, and out of those 12 women who have been positive, where their male partner have been negative, became pregnant, and they delivered, and of course, they also had a negative child. That's why they have been positive. They have undetected viral load. So this very clearly shows it is possible, but on the other hand, you need to do a package of counseling and care, not just like prescribing. Make sure that they take it. If they don't take it, it's not going to work. Instead of, you're trying to protect, that woman, but also you might end up in transmitting to the baby. So I think you need to do all these types of counseling, before you, prescribe these, PrEP. So here comes where I asked this question to Dr. Mayer. So many of our patient population, they asked me, hey, can you give me something where I can take it and forget for another 2 months or 3 months? I think this is something what I've been personally been interested, and a big lobbying of these long-acting antiretroviral drugs. So now 25 years of practice of prescribing antiretroviral drug, it's a life-saving drug. It had made wonders. Make sure that today HIV-infected people need not die if they take the drug. But again, taking this drug, they have been fed up. So they keep asking me, both as a patient as well as in a, for a PrEP, why not give me something which they can either inject or swallow once in 2 months or 3 months. Now we have two, good studies being presented called HPT and 083, which was conducted among MSM and transgender women, and another study called HPT and 084, which was been conducted among high-risk women in sub-Saharan Africa, where they had compared oral PrEP, which is with the Rawat, tenofovir, entrectinib, against the long-acting injectable antiretroviral called cabotegravir, which is an analog of dolutegravir we use for treatment. And again, in this particular study, they use this cabotegravir every 2 months as 600 milligram intramuscular injection. So again, they found in this study where again, Dr. Mayer said that again, we need more time, to get this data to be rationalized into the, in the population as well as to the regulators. But the study very clearly shows that this long-acting injectable is superior to the, oral PrEP. This again might be because of this adherence issue. This is a major issue. Again, all the studies have shown in PrEP, you don't take it, you won't see this efficacy. But on the other hand, when you have been giving this in your practice for pregnancy, you have to make sure that these new drugs are safer in pregnancy. There is very little data available, especially on the usage of cabotegravir in pregnancy. We do have a good data on the usage of tenofovir and entrectinib or tenofovir and lamivudine as an oral PrEP in pregnancy, which has been safe. And when I browse this literature, I think there's only one presentation on this usage of this cabotegravir in pregnancy, but again they showed it's on a very smaller group of 13 women, which was presented earlier this at Retrovirus conference by the innovator company ViiV, where they didn't see any birth defects. So it could be safe, but on the other hand, we need more data, as said by Dr. Mayer, before we implement it all. But on the other hand, I'm very optimistic probably this long-acting will play a huge role in India, especially in the context of adherence. So I'd be happy to take the next question. I think in one of the major things we do in our practice is implementing PrEP is among serodiscordant couple, particularly in the context of having a negative child, which is again our culture, which is a needed one.
Thanks, Dr. Kumarasamy. I will come back to you after I ask some other questions to other panelists. So I will ask, I think, a question to Dr. Gilada. So because the discussion was on PrEP in private sector, so what do you think needs to be done to improve the skills of the private healthcare providers so that they can able to prescribe PrEP properly? So, and also you are also a president of ASI, so Age Society of India. So are there any plans to the ASI you are thinking in terms of improving the skills? I think the skills not only in terms of say only the clinical, but you also discussed about stigma discrimination faced by key populations in healthcare settings. So to improve that situation also, what will be your say suggestions or what needs to be done to scale up PrEP in private sector?
See, first I will talk about what ASI has done and will be doing. For last several years, I think from 2005, we have been having conferences and discussing all these issues. For last 7 years, 5 years, we've been talking about PrEP every time. We have been bringing NACO people, we have been bringing other policymakers, planners, and every time there has been a dialogue. The problem is government of the day. For example, if you look back about 15-20 years back, when condom promotion started, one minister came, she put condom in her office, huge condom in her office. Next minister came, she said no condom advertisement on television, no condom anywhere. So it depends on government of the day. Secondly, if you allow condom, why don't you allow PrEP? It is a physical barrier and this is a medicinal treatment. So both are preventive measures. Thirdly, if you are looking at treatment and providing every treatment free of charge, when you are providing treatment free of charge, do you want more and more people to get infected so that you can keep on treating? So if there are some preventive measures available, which are established internationally, which are approved in our country, why not to use? Now, when we talk about private practitioners, as a private practitioner, any doctor can use tenofovir emtricitabine or tenofovir lamivudine or tenofovir TAF and lamivudine, TAF and emtricitabine. Now, there is very little gap between PrEP and PEP. For PEP, basic PEP, we are using the same drug. So if a private practitioner is giving some drug as PEP and that also works as a PrEP, no one is going to stop him. Any drug which is approved by DCGI and marketed in the country can be used for another purpose which is also approved anywhere else. So no one is going to stop them. As far as government is concerned, government have their own system and way, but current NACO officials, they have been very cooperative. When we have it, we are talking to them, they say, yeah, we'll do it. Probably this COVID mania, which has taken over and overshadowed HIV work, is not only for PrEP, but for everything in HIV. A lot of researchers will be taking a backseat internationally as well as nationally. Now, Kumar is talking about cabotegravir. We are talking about tomorrow. What about today? Cabotegravir may take longer time to come. So we need to emphasize what is available today, and probably all practitioners, whosoever is in the field of HIV, they should walk 1 mile extra. Talk to people, talk to community, what is available, where make them available there. If there is a grinder, Tinder, they are available, they have not been stopped by the country. That means you can always reach those sites, whether social or physical, with these kind of messages, and it will be done. It is not that difficult. But sometimes, as practitioners, we are also blinded what is happening where. For example, one of the patient came and he told me that they have several partners. I said, where do you, which hotel you go? Oh, sir, we don't have to go to hotel. Where do you have? In theater, in a cinema theater. I said, which theater? And that theater is on the same road where my clinic is located. So I said, how do you do? He said, when theater is on, movie is on, all these sexual activities are going on in theater. So if these things are going on, we are not able to stop them. We are not able to regulate them. So we need to provide preventive measures. And by providing preventive measures, if you provide, say, food free of charge, people are not going to eat 4 times or 5 times. So something which is available and made available, it's not going to be that people who are not using, not doing anything, they will start doing because PrEP is available. I think that is some foolish argument. The same argument has been there for condom usage for almost 35 years. Condom was never a popular device for STI prevention, and by OBGY people, they always say use condom. They never said whether condom is a chewing gum or to be used on sexual organ. But HIV practitioners have made it happen. Now condom is a very popular device. It was never earlier. So I think HIV practitioners or PrEP practitioners can do and play a great role. I request the community people, be in touch with whosoever doctor you know. If that doctor is not willing to support another doctor, but they can also approach ASI. As an organization, will always support the community.
Thanks, Doctor. Can I ask Shruta to address questions to Dr. Sagai and also to Mr. Abhishek?
Sure. Thank you, Venki. So, Dr. Sahay, the question that I have for you is, what can be done to strengthen behavioral research around PrEP? You spoke about it in your presentation, but it would be very helpful if you could, provide the next steps in research that could be indicative for all of our audiences, agencies, and community-based organizations too.
So as you know, thank you, Shruta. As you know, disease, like prevention, it is a huge behavioral issue itself. Prevention, health, even preventive health is a huge behavioral issue, and PrEP is one of that. One of the things of which we are talking about. Dr. Gilada is talking about the similar things. So the research that we really and what we are seeing in the FSW trial demonstration project and the project that I'm doing right now, we need to find out strategies to reach the key population. The key population as a community, they think that they are visible to all, but basically they are not coming. What we are seeing in our demonstration project, they are not coming. But one thing that I have learned through COVID is, yes, it is the social media. So social media strategies to reach these populations is going to be extremely important for the program also. So it in a real research kind of way, we have to generate evidence that these strategies would work. And one of the strategies which is working for us right now is going through what Dr. Gilada just now talked about, going through Grindr and Blued and all those social media, and we are able to reach them. The second research that we really need to do is about adherence. Adherence, long-term, sustaining long-term adherence, as Dr. Ken Meyer also talked about, he talked about adolescents and sustaining adherence in adolescents. And again, we are seeing this. This is too preliminary for me to speak about our data because it's just now we have just initiated, but we are experiencing that it is very difficult to have adherence, optimal adherence among the adolescent, particularly youth, which is around the age of 19, 20, you know, college going youth and all. So the research around adherence is going to be crucial for PrEP. And one point that I wanted to make, why prevention, why PrEP not on demand and all those things. So this again, we need to research. We need to involve all the stakeholders. So kind of multi-stakeholder analysis to really understand why not PrEP on demand. So if it is required by the community, so what are the issues? If the issues are medical monitoring, then community needs to understand. So it could be research on community literacy as well as research literacy in the community. So these kinds of studies need to be taken up to make a way forward for PrEP.
Thank you, Dr. Sahay. I'm going to come back to you with a couple of questions maybe later, but first I would like to, have some questions for Abhishek. So Abhishek, the questions that I have from you are, of course, from a very community perspective. One being, what was your biggest challenge and what were your biggest concerns while you went on PrEP, and how did you overcome them? And the next question that I would have for you is your one suggestion to policymakers who are listening with regard to PrEP, as well as one advice for community people. So you've got actually 3 questions awaiting you. So yeah, go for it.
Yeah, thank you so much, Shruta. So to answer your first question about challenges that I sort of faced when I decided to get on PrEP and when I actually got on it. I think one of the biggest challenges initially was also just accurate information about the drug, right? Because I mean, this is really like about 4 years ago, I believe in like 2016. And we had heard about this magic blue pill that's there in the US, and that's going to take care of prevent HIV, right? And at that time, I mean, it sounded all nice, but it just sounded, American hogwash. And I think it was really after conversations in and around, with people. And I remember getting in touch with you that I was very aware of my sexual practices and behaviors. And I knew that this is something that I wanted to really consider. I remember I have a conversation with you. I reached out to you at Humsafar, and then you put me in touch with a doctor at that time. I think after being put in touch with the right people is when I got the right information. And I think that is what happens with SRH generally in India, because there is so much judgment and stigma around it. There is not a lot of accurate information when one wants to access sexual and reproductive health services. So often people rely on really word of mouth or the internet. I remember me getting onto Facebook groups that were about PrEP, not really based in India, but at least I could speak to people, either they were activists, doctors, researchers who were on the group, right? And talking about this drug, its side effects, or how does one even take it, adherence and all of that. And so really access to information was one of the biggest challenges. And I think the second one was not really around, will this work or not? I think it was more around, if I get on it, like, am I supposed to be vocal about it? Do I take it secretly? What is going to happen? I mean, how do I have sexual interaction with partners? And I think it was the stigma really around that as to what will I be looked at if I get on this pill was another challenge. Because I feel, the question that Dr. Venkatesh put forth before to Dr. Ken were also things that I have heard, that, oh, why not condom use? That why not just push for condom use? What about STIs and all of that? And I think, risk assessment is something that we need to sort of think about when we talk about that, right? And I mean, I know there are a lot of doctors in this room right now, but also, if I'm not mistaken, actually condoms have never been approved for anal sex by FDA. And so thinking about risk assessment, that the same people who would tell me that, oh, but what about STIs, condom use and stuff, would assess and negotiate their own risk and safety when it comes to oral sex and condom use, right? So it was something that I had to sort of debate and negotiate with myself and get over that, because it's not just from the provider, it's not just who I would go to get PrEP, but it would also actually be internalized stigma, slut shaming, and all of that from within the community too. So these are some of the challenges that I had to overcome at the time. I think to answer your second question, which was regarding advice to policymakers, I think as the conversation around PrEP is opening up in India, programs are starting to get rolled out. I think one of my suggestions to policymakers would really be around like a few things, right? Information, something that I already mentioned, but then also like accessibility, affordability are some things to think about, because we have heard a lot during this webinar from our esteemed panelists around, PrEP and the private sector, right? But I would really push policymakers to view this also from the lens of how do we make this a public conversation as well. So whether that is about normalizing PrEP, just as condoms are today normalized. And the second thing would also be to, because as someone from the community right now, PrEP is very much conversation for gay men, and especially privileged gay men who can access that. So how do we move this conversation to others who are, whether they are come under high risk group or not, but how do we move this conversation beyond just privileged gay men who can access this? And to answer your another suggestion would also be something that Dr. Sahay and I believe other panelists also talked about is, a lot of the trials, they are including trans persons, right? So I think that is something I would also want to highlight policymakers, that having more trans-inclusive programs being rolled out for PrEP. And to answer the last question on what was that advice to community members who might be thinking about getting on PrEP?
Yes, that would be it, Abhishek.
Yeah, I think community members should really, if you think about it, I think that's great. That is the first step, because you're probably also evaluating your own sexual health and practices, right? And I think that's never a bad thing. One thing I would definitely tell you is, if you actually do get on PrEP, you would be more aware and screen yourself more for STIs much more often, right? And the other thing is really that, do not like access the correct information. Do not, fall into the trap of sort of like rumors of word of mouth. And then your sexual health is going to be your responsibility. And because you're considering PrEP, it does not mean that you're going to have to give up condom use. You need to think of PrEP as one of the tools in your HIV prevention toolkits. And it is so important that to policymakers, that PrEP is present as one of the toolkits for the community, because this has been stressed on before, but monogamy is not an option for everyone. Condoms are not an option for everyone. So that is why we really do need PrEP as one of the tools in the prevention toolkit.
Thank you, Abhishek. That was very insightful, with a lot of food for thought for not just policy makers, but also for community members. Dr. Chakrapani, I would like to ask you to come in. There are a lot of questions waiting in the Q&A section, and if there's anything in particular that you would want to take ahead.
Yeah, Shruta, it's almost time. I think what we can do is we can pose one question to each of the panelists from the audience, if you can identify. And then after that, we can end with a key take-home message each from the panelists. And then I think we need to close maybe in another 10 minutes maximum. Yeah.
Okay,
so,
thank you,
yeah.
Doctor. So actually, there is a overall theme, and I'm going to kind of, since you've given me the option for one, I'm going to make it two. So one is that, does NACO PrEP guidelines that are currently on do they talk about a framework for all of the practice that happens throughout the country, or they only limited to the public health facility? So that's one question. And the other one that I would want to focus on would be with regard to women and PrEP, like considering that we are in a patriarchal society where sexual health of women is something that's a very difficult aspect to negotiate, particularly with female sex workers. So is PrEP an answer to that? So, I would just hope for panelists' opinions on any of these two or both. So, yep, that's that.
Firstly, NACO has not yet finalized the guideline. The guideline, once it comes, it is for both public and private. Mainly for public, because privately everybody is currently using it. Now, when you look at PrEP for women, PrEP for the sex workers, yes, it is one of the great assets to them. The most important thing people should understand that PrEP or medical PrEP is only for those people which will be 100% successful or 85-70% successful in discordant couples, where you are certain of each other's other STD behavior or practices. If no other STD is there, if a discordant couple, mutually monogamous, then PrEP will be fantastic. But for all other purposes, PrEP is in addition to condom. PrEP is in addition to condom. You must understand that thing, one thing. Secondly, at least 2 infections can be prevented through vaccines, that is HPV and hepatitis B. And hepatitis B is very much prevalent, so much so, and it is so easily transmitted, is at least 70 to 100 times more transmissible than HIV and 10 times more transmissible than hepatitis C. So if those 2 infections are prevented, is if you are taking PrEP for HIV, at least 3 major infections are prevented. Other infection, a lot of STDs are completely curable, barring hepatitis, barring HSV or herpes. All others are curable. So one need not be so much worried about other infection. There was a question in chat box about syphilis. Is syphilis that dangerous? Syphilis is not that dangerous. It is dangerous because a lot of doctors do not want to give injections of Penidura or penicillin, long-acting penicillin. Secondly, penicillin has become an orphan drug. Rarely 1 or 2 companies are making penicillin, and that is not easily available. So if somebody has to fetch penicillin, has to go to at least 20-30 shops, then you can get 1 injection of penicillin. So that is a problem with syphilis. Otherwise, syphilis is completely curable with long-acting penicillin, 3 dosage at weekly interval.
Thank you, Dr. Gilada. Would any of the other panelists like to address any of the questions that were just shared?
I think one of those questions which was addressed was on how we can strengthen the private sector in implementing PrEP.
Sure.
I think doing a lot of educational program for physicians is important. As Dr. Gilada said, that through AIDS Society of India, we have been doing through all our annual conferences, there is a dedicated session, half-day session with a plenary, we do that. Also, we do a lot of regional meetings for antiretroviral treatment meetings, where in that we introduce a topic on PrEP, mainly for the clinicians to learn on that. And it's not only for these HIV clinicians. I think the educational program should also go into those other general practitioners, obstetricians, and everyone. So it's very important, because these PrEP can be very easily prescribed, and the only thing you need to have a patient enough to speak to those people. They are not even patient; they are all normal people, negative people. Speak to them that how to take it up, the importance of adherence, doing screening for HIV and hepatitis B. Make sure that they take this drug is all very important. I think repeated educational program, not just on the PrEP antiretroviral drug alone, but also on the package of PrEP, that is counseling, testing, all those should be done. I think this is something what our government should also look for when they have been implementing these national guidelines, not just implementing guideline, but also how you train all the providers to do that. These drugs are available. The cost varies from clinic to clinic. It could be anything from 700 Indian rupees for a month of PrEP, or even less, to up to 1,500, depending upon the clinic, how much they have been, using this. But again, still, there was a question in the chat box, why Drug Control of India don't give approvals to the new drugs. And of course, always regulators, they look into the safety data on different from clinical trials. And also Indian regulator, that is DCGI, always looked into the safety of any of those new medications in the Indian population. So this is a requirement. I'm sure you might be seeing all this in the media, even for these emergency situation for COVID. They look into that very seriously. I think that is very, very important. Let us not rush on that. I think safety is very paramount, on such measures. But I'm very sure that, these long-acting injectable, which I mentioned, called cabotegravir, will get into India, as Dr. Gilada said, may not be today, might be, in a year's time or even more, will be available. And as Ken said, it might be very expensive. We have our Indian generic companies who can manufacture anything in a record time, and they can reach your doorstep even at an affordable cost. I think giving a 2 monthly shot is something what we need. Maintaining this adherence along with the prep is going to be a monumental task. So I think this long-acting will play a huge role, especially in India, in the fight against the ending AIDS epidemic.
Thank you, Dr. Kumarasamy.
One thing in that, about other PrEP drugs like tenofovir and 3TC. Because innovators, they do not have combination of these two drugs together. They always tried only TDF-FTC. And therefore, the initial approvals are only for that drug. But WHO had made very clear that FTC and 3TC, they are interchangeable. And they have found the results are similar. So there is no need of a different data or different study to be done. What happens in India, when DCGI tells our pharma companies that you do a study in India, that study costs them huge, maybe crores. And when they know that the market is not so much, they are not going to spend on that. And thirdly, what will happen? Most of the drugs now are available 3-in-1 combination. So this TDF-FTC or TDF-3TC may be extinct after some time, because if everybody is taking 3-in-1, either this combination, that combination, or that combination for treatment, then the TDF-FTC or TDF-3TC cost will not come down further. It may increase, or it may not be available. So we need to ascertain that these drugs will remain available.
Yeah, thank you. I think considering the time, may I ask each of the panelists to just say take-home message, maybe 1 or 2 take-home messages, and then we can have the vote of thanks from Shruta. Yeah, I think I will start with Dr. Sahay.
Thank you, Dr. Chakrapani. My take-home message would be, like, community should come forward, even if this is a great step towards what we are doing towards PrEP, but still what we are seeing is not the demand. So demand generation by the community for the community is extremely important, and I must congratulate you all for this particular step. So that is that is one of the messages that I would give. And yes, adherence studies would be extremely important for PrEP.
Yeah, but I think demand generation is also a responsibility for other stakeholders like government, right?
Sure, it is. And
Yeah.
I think NACO is going for the guidelines, and that is one step, that's one positive step that we are seeing, and the demonstration project that we are also doing among MSMs. But people are not MSM people or the transgender women. We are finding it difficult for them to get enrolled. So it is free. PrEP is available free in our project.
So raising awareness about that and talking
Right.
about the usefulness, I think, yeah.
Right.
That way we need to
Going
create
right into the hidden population, or the population which is really marginalized, they should be educated. So some kind of education strategy is required for them. Thank you.
Thank you, Doctor. Yeah, Dr. Kumarasamy.
Yeah, I think I'm repeating the same thing. What I said is a carrying on message. India needs biomedical prevention in the form of PrEP. There is no doubt in that, and science shows this works. When science shows works, I think we should not say only the community should. I think we all, everyone, the providers, community, the government. I think even we need a lot of support and encouragement from these pharmaceutical companies, how they can bring it forward in a way that they can reduce the cost, and because they should not look at their business on this particular PrEP. How they can use it as a public tool in preventing this transmission. I think the very important take-home message is implementing PrEP will facilitate, which I feel, end this AIDS epidemic in India. I think it's very important, not just alone condoms and STI treatment and treatment as prevention. I think coupled along with that, this PrEP will definitely move forward. And there are a lot of newer things coming up, not just alone this oral PrEP. Now we have these long-acting injectables, and also now we have got a lot of newer ARVs under development as a long-acting or as an implants, where these antivirals can be put as an implant where it can stay there up to 6 months. So now there are 2 new drugs under development, one called Latravir, another one called Lenacapavir. This works at the different levels at HIV life cycle. Also, they found in those studies, it also has got a higher penetration in the tissues, particularly in the rectum and in the vaginal tissues. So these drugs can be wonderful PrEP drug, but not been studied yet. I think, we have a lot of newer drug, in pipeline. So I think right now, as Dr. Gilada said, we should use it, what is currently available as a oral PrEP, that is tenofovir and denividine. I think we should use it and implement. I think this will help to end AIDS epidemic in India. Yeah. Again, thank you for this opportunity as part of this wonderful panel.
Thanks, Doctor. Yeah, Dr. Gilada, your message.
See, you organized this event on the very important day, which is the International Human Rights Day. And day after tomorrow, there is a Universal Health Coverage Day. In between this, having such kind of program, you must have a PrEP march. Let people march for PrEP. Secondly, conceptually, whether you're talking about COVID vaccine, HPV vaccine, hepatitis B vaccine, they're all PrEPs. They are prevention. They are injectable PrEP. So if those PrEPs are available, why to stop this PrEP? And thirdly, okay, this PrEP may be contributing 1%, 5%, 3% prevention. That way in HIV, HIV transmission through blood transfusion was 2 or 3%. So why did we concentrate on blood transfusion? Why did we support all blood banks for that? So whether it is 1%, 2%, 3%, unless until we cover entire population with whatever gametes available, we will not be able to have zero infection by 2030. So if you are talking about 0, 0, 0, it's not going to be possible. So I don't think government is averse to this, particularly state-aid societies currently and NACO. They are very much open. They're very much pro-community. So only thing, the community voice sometimes becomes weakened. So I think you must strengthen your voice. And these are the 2 good days to publicize, reach wherever on social media, conventional media, and make it happen.
Yeah.
So, see that the guideline gets passed before a couple of months or so, or otherwise you have a PrEP march. Thank you.
Yeah. Thanks, Doctor. Yeah, Abhishek, would you like to also convey a message?
Yeah, I think a lot has been said, so I'm not going to repeat. But I think like just a couple of things to like the community, that it's not that like condoms don't work. Condoms work. It's people who don't work, and PrEP gets around that human element of not using. So your efficacy, even if you miss one pill, it's not going to drop to 0, which is what happens when you don't use condom once, right? So just thinking about that, if you ever consider PrEP. And I think to adding to what Dr. Sahay said, and just something out for all stakeholders that are involved in PrEP, that the community doesn't even know that it is available for free, right? So how can the two sort of work together? That how are we going to publicize this? So all stakeholders here have to play a role. There's someone in the comments who talked about medical students, right? I feel like medical students are the future, and they play such an important role in how communities are going to move forward with access to healthcare, and especially non-judgmental healthcare, right? So similarly, I feel like the onus lies on multiple stakeholders. I think policymakers definitely need to keep this in mind, that how are we going to make people aware that such a thing exists so that they can access it. So the demand also increase through that. Thank you.
Thanks, Abhishek. I think now I will invite Shruta to propose the vote of thanks for our excellent panelists and speakers. Yes.
Absolutely. Thank you to all of our panelists, Abhishek, Dr. Kumarasamy, Dr. Gilada, Dr. Seema, and Ken for the amazing presentations. This has been like a storehouse of information, so glad to have you on. To Dr. Chakrapani for conceptualizing this and for putting this together with C-Sharp and Woodley, of course. Another vote of thanks to APCO Worldwide for being our partners with this event, and to Dinesh at the Humsafar Trust for manning everything, the tech part of it, as well as my beautiful family at the Humsafar Trust for all of their support and love. Attendees, we are 20 minutes over time. Greatly appreciate your enthusiasm for staying right on till the end. And a big thank you and a lot of gratitude to you all. So that's my vote of thanks. Doctor, we can now officially close.
Yeah. Thank you very much. Yeah, thank you.
Thank you.
Yeah.
Bye-bye.
Bye.
Bye.
Kumar,